Good afternoon. Thank you for having me today. It's been a fascinating conversation. Back in 2003, I was a researcher doing community-based research on adolescents and their families and obesity treatments. And I became really frustrated that we couldn't get reimbursed. It was myself, a nurse practitioner. I'm trained as a pediatric clinical psychologist, and a nurse practitioner, a medical doctor, nutritionist, and we had NIH grants, but we had a hard time getting reimbursed for these prevention services. And so unless you fit our very strict clinical protocol, you are on my 6-month, 7-month waiting list of parents and kids wanting help, basically. However, if you were determined that you needed bariatric surgery or some very, much more medical intervention, then that could get reimbursed. You would go up to the hospital, and then, maybe they would then pay for lifestyle changes or whatever, the fluffy stuff. Then you would come back down. And so I thought in 2003, I'm going to take a American Association for the Advancement of Science Congressional Fellowship and change the world in a year. Well, it took us through the Affordable Care Act about 10 years, but I caught the bug, and it was, I totally agree with what folks are saying here, and the conversation has just been absolutely fascinating this morning, that not everybody needs to do the same thing, but for me it's been really rewarding. And so I obviously caught the bug, stayed here for a year, then I did actually a AAAS diplomacy fellowship, and was at the State Department for a little year and a half or 2 years doing international health. And then I was called back to the Senate, and I was the Chief Health Director for the Health, Education, Labor, and Pensions Committee over the last several years with Chairman Tom Harkin, who is the person that did put prevention into the title of the CDC. So you can kind of see where my charge has been for him, and it was a very nice working relationship. And through the Affordable Care Act, the charge from him is that we cannot have a sick care system. We can't have a health care system. We need a health system, and public health, prevention, population health has to be part of this system. And so that's where I have been and what I have done until end of December. After we got the Surgeon General confirmed, we were able to do incentives for the Ebola vaccination and some other things. Then my boss retired, and I, for the last 7 months, been with Merck Pharmaceutical, thinking that is another place. I'm within the policy communications and population health. Dr. Julie Gerberding is my big boss there. So again, having at least a public health thought in this. Here, we are very much into vaccinations. Merck for Mothers is where we've put a 10-year, $500 million initiative to reduce maternal mortality, diabetes, oncology. We've also started a council really looking at antibiotics resistance, but dealing with the issue that we have a dwindling pipeline of antibiotics. So now how do you find that right policy where you're having enough stewardship, but at the same time developing the antibiotics you need? Hepatitis C, and we are working really hard to see what we can do in the Alzheimer's space as well. I think, you look at this, and I know when I was back in the Senate, and I'm going to go back and forth between my different experiences. In the Senate, people did not understand community prevention. I mean, when I talked about the Community Preventative Services Task Force at CDC, people looked at me, they probably still would, like I had 4 heads. And, and so we were able to introduce to them at that point the clinical prevention, clinical population health, and that's where we developed also on the community side the thought of having a laboratory, that slush fund that is looking to be repealed again tomorrow, I think, the Prevention and Public Health Fund that we were able to develop back then, and trying to teach people about population health, community interventions. I think as Ron was alluded to, this got obviously very politicized, people saying that jungle gyms and sidewalks are just, awful and just very not going to advance population health. I talked to folks and they say, I think we need to, up on the Hill, I think we need to come up with a different vocabulary. People just don't get it. And, and that's why when Paula was talking about medicalizing this, this worry, this tension, and what do we do? Are we at crossroads? Like, do you at some point say, well, let's try to get population health, part of it, into the health system, into the fabric, so it's part of the reimbursement system, like clinical prevention is. And what do we need to do? Do we need to use research to understand the integrated person? I know what Merck is finding is, great, you have a cure for, Hep C or something, but if you don't understand the community and the other factors that support this person, they then are passing away or getting sick from another issue. So it's whack-a-mole. You really have, and that's what Merck is doing, is imperative to understanding the entire community as you're developing your interventions. Also looking at adherence research. Our vaccination practice, they have all kinds of research looking at tracking on beliefs. What is the barrier for someone to taking the intervention, for having the vaccination. Also looking at process improvements and how can we increase the appropriate adherence to different vaccinations. But I think something else that I think is fascinating, and this is just me talking, is as we're looking at these health systems and delivery systems reform and all these different metrics, I hope people are looking, when we're looking at the value of this health system, how are we moving the needle on population health? I hope that's a metric. I know NQF, I think, is having a meeting in the next week, in a couple of weeks or so, and looking at these quality measures, because we can all talk about value and reimbursement, but what's is our population actually becoming a healthier population? And then lastly, what does this mean? I think this is a good thing, but what does this mean that if our population is healthier and we're living longer, what does this impact have to our entitlement programs? And how are we talking about that? And I think, we need that research, because if we don't have that research, unbiased facts, politically, this could become, I already hear, and it's true, the Congressional Budget Office makes us pay for some different programs we do because they'll say, well, the people are going to live longer, and that's going to cost us money. And I think you all have probably seen some of that research, and that would be something I would deal with constantly with CBO. I think, and I've just totally, this little bit on population health, so really also looking at the value, the cost containment. And the reason I brought up the cost containment is when we're looking at the policy at Congressional Budget Office and scoring, they finally, several years ago when we were doing, I'm trying to think, CHIP, gave us cost savings for smoking cessation, because they actually found that stopping someone from smoking actually outweighed them, making them healthier. So we actually got savings. All of our other prevention programs, I know the diabetes prevention program, other programs, we are still fighting that battle. So also economic analysis, and really, Jeff's heard me say this a lot, really making the case that this is, and maybe we don't want to, but that this increasing the population's health would save money, will help support passing more policies in the federal government, since it's in such a budgetary time that you have to pay for everything that you want to pass. So those are just some of the things that we're dealing up there. I get the other research item that, Ron, you brought up about these premium support Medicaid expansion programs. Several of them, I know the one in Iowa for sure, I think you all will find this interesting, they're making part of it that these folks have to take health risk assessments, and they have to do all these different programs that of course you and me don't have to, but okay, our folks that are trying to get Medicaid, they have to be very well and have to take more responsibility. So it would be really fascinating what the research is in those states that are, basically making a requirement that these folks then do these health risk assessments and what they do with that. And is that moving the needle on population health? Is that actually a barrier to people getting into the Medicaid program? I think that could be very interesting. And I guess I'll just lastly say, for going to the Hill, folks that are interested in being advocates for the Hill, the Senate, there's 1 or 2 health advisors for every senator. Your information is vitally important to them. I knew my deans at the schools of public health. I knew all the different public health departments, and they'd shoot me their abstracts, and they just let me know. And it was just good to know what was happening. All politics is local. It's so important that your folks know that public health and population health, it's real, it's important, it's not just, I think so many people feel like it's just the nice thing to do, and that, this is really the future of where the health system should go and be part of the dialogue if we're really going to talk about a value, quality, accessible health system. Thank you.
Thank you, and thank you to the panel.